So it's now my immense privilege to announce our first Michael, Professor Michael Hofman. He's a nuclear medicine physician and a professor at the prestigious Peter Mac Institute in the University of Melbourne. He is the director of Prostate, which is a diagnostic center of excellence in prostate cancer. He has led so many clinical trials that are landmark trials. Think therapy and pro-PSMA. Really such an impressive author and researcher. He's also a member of ArtNet and he's editor of several journals, including Journal of Nuclear Medicine. Personally, I admire him so much for his social media presence, and I think at some point he must give us a masterclass on that. It's now my privilege to welcome you. Thank you so much, Prof. Mai.
Thank you so much for the kind introduction, and thank you to all the organisers for inviting me to this meeting. It's a very impressive meeting, and it's good to see that so much strength in nuclear medicine in South Africa, really high quality talks, and in some aspects such as alpha therapy, good to see you really leading the world as well. So my talk is going to be on prostate cancer, where are we now? And then tomorrow I'm giving another talk, which is a little bit on more exciting stuff that we're doing at the moment that'll read out over the next few years. Here are some of my disclosures. This is the theranostics program at Peter Mac. We started doing lutetium dotatate therapies back in 2005, and the program's been growing constantly. I think the last bar there is actually 2021. Last year, I think we did over 800 lutetium therapies at our centre, and it's gone from being all neuroendocrine tumours to being predominantly PSMA therapies now, although there's still a large neuroendocrine tumour volume that you can see there in red. And the green colour is radioactive iodine, so still a good volume of thyroid cancer patients being treated as well. I think this year we're going to actually do as many as 1,200 lutetium therapies at Peter Mac, so the program continues to grow. We started doing PSMA therapy back in 2015, and what we did differently to our neuroendocrine program is that we did everything prospectively initially as part of clinical trials with really rigid inclusion-exclusion criteria. We did this to really try to provide high-level evidence and work very closely with our oncologists. And this small 30-patient trial, which was expanded to 50 patients, was presented at the European Medical Oncology meeting in 2017, and we showed a PSA response rate greater than 50% in 64% of men, and these were men who had really failed all forms of prostate cancer therapy. And at the time, this information was not really that new, because our German colleagues, and probably even here in South Africa, had been also doing lutetium therapies, even predating us for prostate cancer. And I think this highlights how even a very small trial, only 30 patients, done really strictly in a prospective manner, can influence global practice. Whereas if we study hundreds of patients, but it's retrospective, our oncology colleagues look at the data and they don't quite believe it. They think it's really sometimes biased. They think we're cherry-picking our patients and not necessarily reporting data accurately. This was an image from the trial of the 8 best responders with PSMA PET scans before and after treatment. These images were all produced on MIM, which you just saw in the lunchtime symposium. We contoured all the activity with an SUV above 3, and we generate really some beautiful pictures. This was awarded the Society of Nuclear Medicine image back in 2018. But what you may not know is that we included this image in our Lancet Oncology publication, and Lancet made us take out the image. They said, you can't put this image in the paper, it's biased because you've just cherry-picked the 8 best responders. You haven't got figure 2, which is all the patients who didn't do well. And we said, okay, we'll move the image to the supplementary appendix. And they said, no, remove the image completely. It's not acceptable. So it highlights the very different ways that oncologists think to nuclear medicine doctors. We really like pictures like this, and our oncology colleagues think maybe it's a little bit biased. Here's an example zooming up on one of the patients in the study. This was a 69-year-old patient who progressed after 4 lines of therapy, docetaxel, enzalutamide, abiraterone, carbazitaxel, and he had very severe back pain from this rapidly enlarging retroperitoneal node, whose PSA was rising quickly with a doubling time, I think, of only 2 weeks. So he probably did not have very long to live and would have gone to palliative care. And dosimetry after cycle number 1 showed a dose of 175 gray to this lymph node. And with such high doses, it's not surprising that he had a good response. And after only 3 doses of lutetium treatment, his PSA was undetectable. And you can see the CT scan showing that that lymph node had shrunk to become sub-centimetre. But important to note that we don't cure anyone with this treatment. Out of that 50-patient study, 49 patients died of prostate cancer and 1 patient died of a myocardial infarction. So it remains a lethal condition, and patients do progress after lutetium. This patient had quite a durable response for about 18 months, and when his PSA started rising, we treated him again and gave him several more cycles, and he lived for about 5 years, despite really being critically unwell when initially presenting. We're lucky to have a research nuclear reactor in Australia, maybe similar to what you have in South Africa, ANSTO, that makes lutetium-177, no carrier added. This has really enabled some of this trial work. ANSTO has been very generous in providing us either with free or discounted lutetium for our clinical trials. We went on to do a large randomised controlled trial in Australia called the therapy trial that I'll show shortly. And shortly after the therapy trial started, the vision trial also commenced. This was the registration study from AAA Novartis, a very large trial. This is the results of the vision trial. They took patients who had progressed after an androgen receptor pathway inhibitor and at least 1 taxane chemotherapy, and they were randomised to either lutetium PSMA 617 or protocol-permitted standard of care. The doctors weren't quite allowed to choose what they wanted. It was defined by the protocol, which was essentially a crossover androgen receptor pathway inhibitor. And patients were followed up with a primary endpoint, really, of overall survival. And here is that OS endpoint showing an improvement with a hazard ratio of 0.62, about a 4-month improvement in overall survival. A larger difference if they looked at radiographic PFS, 8.8 months versus 3.6 months. And this slide of radiographic response on CT really highlights how active lutetium treatment is. If you look at the 2 on the left, partial or complete response, they really did not occur in the control arm at all. Whereas with lutetium PSMA, if you add up the partial and complete response, there's over half the patients having a shrinkage of tumours on CT. So this is a very active treatment. Recently, there's been a secondary publication from the VISION trial published in Lancet Oncology only a few weeks ago. The reference at the bottom, looking at quality of life parameters. And here is the time to a deterioration in, I think, one of the quality of life measures, the FACT-P score. And you can see really a large separation between lutetium and standard of care, favouring lutetium. So this treatment is not only very active, but improves quality of life. Many other treatments in oncology sometimes improve radiographic PFS or even overall survival, but can have a lot of side effects so that patients experience significant toxicities from the treatment, even if they live longer. But lutetium PSMA treatment is just so well tolerated. Even the patients who aren't responding don't experience too much toxicity. Here's a graph that I've put together from that trial showing the time, and in red is the standard of care, and then in blue is the prolongation with lutetium PSMA 617 from the VISION trial. I'm not going to read through all the parameters, but in pain intensity, functional well-being, emotional well-being, physical well-being, all these outcome measures significantly prolonged by many, many months. So many patients experiencing like more than a year of improvements in quality of life parameters, which is really very significant. They also reported the time to first skeletal event. So this is like a fracture from a bone metastasis and a hazard ratio of 0.5 significant prolongation, 11 and a half months compared to 7 months. Now coming on to our therapy study. This was run by the ANZUP Cooperative Trials Group in Australia. Here we randomised 200 men at 11 centres to either lutetium PSMA 617 or cabazitaxel chemotherapy. Cabazitaxel is a second-line chemotherapy. Why did we choose cabazitaxel? But we did it because there was a trial called the CARD trial published in the New England Journal showing that cabazitaxel significantly improved overall survival compared to kind of a crossover androgen signalling targeting agent. So this was kind of the control arm in the VISION trial was the other arm of the CARD trial, and it was shown that cabazitaxel improved survival. So one of the criticisms of the VISION trial is, hey, patients couldn't access cabazitaxel, which was a life-prolonging therapy, in the control arm. Is it a real-world trial, or is the control arm, a little bit rigged in favour of Pluvicto? So in this trial, comparing to a really highly active chemotherapy, we screened all men with a PSMA and an FDG PET, and we collected these centrally and centrally read them. And patients who had either low PSMA expression, which we defined as an SUV max less than 20, so you had to have an SUV max over 20 at least one site of disease, and you couldn't have any sites of FDG positive, completely PSMA negative disease, like you see on the right in the patient with liver metastases. And using these two scans, we actually screened out 28% of men, so almost 1/3 of men were deemed not suitable in the therapy trial. We really tried to enrich it for patients who are most likely to benefit for lutetium. Being a relatively small trial of 200 patients, we wanted to select patients carefully. I want to be clear that FDG positive disease was not an exclusion criteria. So on the left you can see a patient with very highly metabolically active disease, but the PSMA PET shows that all the sites of FDG positive disease also had PSMA activity. These patients were eligible, and we randomised 200 men. The primary endpoint was a PSA reduction of 50% or more, and there was a big difference between the two arms favouring lutetium PSMA, 66% compared to 37% for chemotherapy, and these are waterfall plots. And you can see there's a lot of very deep responses in the lutetium arm, so PSA drops of 80 or 90% or more. And we also looked at radiographic or PSA progression-free survival, and interestingly, the median was not actually different between the two arms. The median PFS is 5 months in each arm, but by 12 months we see a separation of the curve, so that at 12 months pretty much everyone randomised to cabazitaxel had disease progression, whereas 20% of men randomised to lutetium had no progression at 12 months. I've got to say this curve was a little bit surprising when we designed this trial, which was probably in 2016. I thought lutetium PSMA will just blow cabazitaxel apart, and we'll see just huge separation of these curves, and the separation is less than I expected. It highlights really the value of doing randomised trials, that we can see the truth, and the truth is that cabazitaxel is quite an active treatment. However, it does have significant toxicities. As I've alluded to, lutetium PSMA is just so well tolerated. Here's a table of the side effects in the VISION and the therapy trial, and the main side effects are dry mouth. It's usually very mild. No patients having grade 3 or higher xerostomia. You do get some nausea. I think this is actually due to some small bowel irradiation. You see some duodenal uptake with PSMA. And interestingly, the nausea rate between chemotherapy and lutetium PSMA is actually similar in the therapy trial. And we do see some hematotoxicity, but it's generally grade 1 and 2, and only 10% of men having, grade 3 or 4 thrombocytopenia or anemia, which usually resolves. We did report last year the overall survival in the therapy trial, and we didn't show an improvement in overall survival between lutetium or cabazitaxel. The manuscript for this is actually currently under peer review. This was also a little bit surprising. It highlights how active cabazitaxel is, but also there was crossover. So in Australia, lutetium treatment became quite widely available. So patients randomised to carbazitaxel, over 20% of them accessed lutetium, and vice versa. Patients randomised to lutetium often had carbazitaxel afterwards. We embedded a lot of patient-reported outcomes in the therapy trial, and these strongly favoured lutetium PSMA. So really every single domain we looked at was superior with lutetium. There were no symptoms that were better with chemotherapy, and some things like skin rash, neuropathy, hair loss, altered taste, having very large differences favouring lutetium therapy. And I quite like this parameter on the left, which is called a deterioration-free survival, which is a time to a 10-point deterioration in overall quality of life, which is a big difference. Progression or death or treatment discontinuation, and you can see there's quite a large difference favouring the lutetium therapy. I think these two trials, Therapy and Vision, are only just the beginning. They're both in patients who have progressed after a lot of treatments, hormone treatments, chemotherapy, and we're now interested in moving this treatment earlier, which is already happening here in South Africa, where it's used quite commonly before chemotherapy, and also combining with other treatments. Here's a patient in the therapy trial. You can see back in 2019, 6 doses of lutetium on the therapy trial, and this is one of the better responders who had like almost over a year of very low PSA and not needing any other treatments. And when he progressed a year later, we gave him 3 more cycles, and he responded very well again. We gave him another 3 cycles and continued on. And he recently had his 20th cycle of lutetium PSMA 617 treatment. This is not many patients keep responding like this. This is, quite I would say, a rare group. Usually by 10 cycles of lutetium PSMA, we are seeing treatment resistance. But, this is an important subgroup. And this patient, remains well and asymptomatic. And I can tell you his renal function is normal, and his blood counts are quite normal as well, despite 20 cycles. And you can see more recently he's become treatment resistant. His PSA's rising despite lutetium treatment, and we're just about to switch him to carbazitaxel, but we're several years after lutetium treatment. So I think in the USA today it's almost impossible to get a 7th dose of lutetium because that's not within the FDA approval. But clearly some patients need more cycles. We're now focused on really how can we improve this treatment, and a lot of it is about patient selection. Is this patient suitable for lutetium treatment? He's 66, he's had docetaxel, he's had enzalutamide. You can see his PSMA PET, he's got mainly bone metastases. His dominant metastasis has a SUV of 22. Who thinks this patient is suitable for lutetium PSMA treatment? Does anyone think the patient's not suitable? No hands up. So I think, this patient meets criteria for therapy trial, SUV over 20. Clearly the intensity is above liver, is suitable for the Vision trial. However, our practice is still to do an FDG PET in everyone. So this is actually a patient on the therapy trial. Here's the FDG performed only a single day after the gallium PSMA PET scan, and we see much more extensive osseous metastases on the FDG. And if we zoom in on these, or if we colour code them, we can just see the amount of disease in red that we just can't target with lutetium treatment. And if we look at the CT scan, which is what the Vision trial did very closely, we can see that these are invisible. These bony metastases are seen on the FDG. They're not lytic, they're not sclerotic. We just don't see them on the CT scan. If you did a total body PET MRI, you would see these. But on CT alone, we just don't see them. If we zoom in here, we can see this phenomenon. So a PSMA negative, FDG positive, and I think FDG PET CT makes invisible bone metastases visible. And prostate cancer likes spreading to the bone, so FDG can be very useful. We've done a lot of biomarker work. There's no magic with lutetium PSMA. It's a form of radiation delivery, and if you can't get radiation to the tumours, they won't respond. From our 50-patient trial, we did 3 time-point dosimetry, and we looked at a dose-response relationship. So we put a contour around all of tumour, not just 1 or 2 sites, but a total body contour, which you can see in red. And from that, we could derive the average grey to all of tumour, and we correlated that with a PSA response. And we could see that if you received less than 10 grey on average to tumour, there were 10 non-responders and only 1 responder. Whereas the other patients who received above 10 grey, almost all of them had a 50% reduction in PSA. We then went back and looked at the SUV mean on the PSMA PET scan and compared that to the dosimetry from the post-therapy, and you can see the relationship on the left, and there's quite a strong correlation, which begged the question, could we just use the PSMA PET scan as a biomarker for response? And indeed, we looked at our initial series and we found a high MTV on FDG and a high SUV mean on PSMA PET were prognostic biomarkers. And then we recently published in Lancet Oncology an analysis that was embedded in the therapy trial where we pre-specified all these endpoints. So we had some pre-specified cutoffs. We didn't look at the best cutoff. A lot of these studies take a group of patients, throw it into a statistical program and pick the cutoff that's best. But that's often not reproducible in another cohort. Here, based on our earlier work, we said if you've got an SUV mean over 10 on the PSMA PET, you're likely to do much better with lutetium than you would with carbazitaxel chemotherapy. And being a randomised trial, we could look at both arms, and indeed we showed this quite clearly. So if you had very high PSMA expression on the PET scan and you were randomised to the lutetium arm, you had a remarkable 91% PSA response rate, so really high compared to only 47% with carbazitaxel. This was also shown in the VISION trial. This was presented at ASCO last year, and similar number, SUV mean over 10, was associated with a prolonged overall survival, 21 months compared to only sort of 14 months in the rest of the patients. So I think SUV mean on PSMA PET is a really powerful predictive and prognostic biomarker, and we do integrate this into patient care. This is a nomogram done with US group, German group and Australian patients all lumped together, 270 patients, and we put SUV mean into this and showed that it is a good prognostic biomarker. So this is how we do it. We do a whole body contour. For the PSMA, we're doing SUV mean above 3. We're routinely using the MIM software. It does make it very quick and easy. We can actually do this in under 2 minutes on average. And for FDG, we've been using a liver threshold. But not everyone has the software to do this. I bump into many people that go, look, we're using the software that the PET scanner vendor provides and we just cannot do this type of quantitative analysis. And we recently looked at a visual score. This is on the front cover of J&M just last month, published by the UCLA group. But it was that same group of patients from that nomogram data for, several hundred men from 3 centres. And we just visually looked at the uptake and we rated it as high, which was uptake intensity above parotid gland, low, which was uptake below parotid, or intermediate, which was somewhere in the middle, where maybe some lesions looked more intense and some lesions looked less intense. And the parotid glands have an SUV of about 18 to 20. So this is kind of similar to a therapy threshold on the left when you've got high uptake. And indeed, just by eyeballing a PET scan, you can see quite good separation in both OS and PSA, PFS. So maybe we don't need even fancy quantitative PET. You can just eyeball a scan, and if the uptake's very high, you're likely to do much better. We're now lucky to have more than 10 investigator-initiated trials of PSMA theranostics running in Australia. These are lots of combination trials and bringing these back to first-line treatments. Tomorrow I'll go through these in my talk. I think I'm a little bit over time, so I might skip a couple slides. Just want to highlight when you do start your lutetium PSMA therapy, it's really critical to work closely with your urologists, with your medical oncologists to do this as a team. and really important to have nuclear medicine embedded in that team, and go to your tumour board or multidisciplinary meetings. So take-home messages is that lutetium PSMA is really a new standard of care for patients who have progressed after an androgen receptor pathway inhibitor and chemotherapy. You should use PSMA PET to select patients. We like using FDG as well. The higher the PSMA uptake, the higher the likelihood of response. Make sure it's a close collaboration, and it's really just the beginning. Lots of trials underway, so there's going to be an explosion of PSMA for managing patients with prostate cancer. I'd like to thank everyone at the Peter Mac team that's done a lot of this work, and all our funding partners and collaborators, and invite all of you to visit us in Melbourne. We're lucky to have a new cancer hospital. That's a very nice environment, and we're running a PSMA teaching course in March next year, which is going to be 14th to 16th of March. We've got a few invited speakers from the US and Germany, and this is a very hands-on course. We've got a lot of PSMA PET scans that we look at interactively for PET scanning, and then a lot of therapy cases, and we go all the way from basics to really tricky cases. So I hope some of you can come and visit us. Thank you.